Hello, I'm Rachel Babin from Oncology News Australia, proud producers of the Oncology Journal Club podcast. In today's episode, Eva Segelov and Craig Underhill cover a great selection of papers. Craig's main paper of discussion is on the St. Gallen International Consensus Guidelines for Treatment of Early Breast Cancer. This is a must-listen for anyone treating breast cancer and for trainees as well. Eva's main paper today is on the challenges of cancer care for the LGBTQ+ community. She's joined by Dr Liz Ahern to discuss this important issue. Quick bites are as quirky as ever, so I hope you enjoy today's episode. You'll find links to all of the papers, bios and Twitter handles in the notes on our website. For regular news and podcast updates, subscribe to the Oncology newsletter on oncologynews.com.au. It's free and it's a great way to support the OJC. This is Rachel Babin and this is the Oncology Podcast.
G'day. Now, Craig, we can take over the mic.
I know. Where's Hans?
Hans had an operation on his hand and no one's seen him. I hope he's all right.
Yeah, I hope so. But it's terrible because, we're going to drop it like 10 Belgian listeners for this episode.
Wow, we'll never recover. But seriously, we love having Hans. Hope you get better. But Craig, I saw that there was in the Sydney Morning Herald an article, critics pick the best new podcasts from the last 12 months. And I looked for OJC and sadly we weren't there, but it did point out that 2 years ago there were around 500,000 podcasts and now there's more than 2 million podcasts. So I reckon we're getting some great feedback. Thanks everyone who sends in feedback. I reckon we should be on that list.
Well, I thought we should write to the editor or the person who wrote that article and actually point out how popular the podcast has become. And then find out when they're doing it next year and we'll start a campaign, get people writing to the journalists. What do you think?
Yeah, sure. I reckon that'll work.
Various people have won the Gold Logies through a public campaign.
Absolutely. So I've got a fantastic paper and a fantastic discussant. Wait till you hear this. Something really, really important, contemporary, and something for everyone. It's my pleasure. Great pleasure to welcome Dr Liz Ahern, medical oncologist who's come down from Queensland to join us at Monash Health in Victoria. She is a T-cell immunological oncologist and wonderful to have her discussing something close to her heart today. So we've had a little bit of a focus on various disadvantaged cancer populations recently, and I was really struck by this article in Lancet Oncology, just published in July, and it's entitled The Challenges of Cancer Care for the LGBTQ+ Community. And it's a commentary that links to a position statement from the Joint Collegiate Council for Oncology, which is an advisory group from the Royal College of Radiologists and the Royal College of Physicians in the UK, plus the Association of Cancer Physicians. And this is a position statement committing to improve care for lesbian, gay, bisexual, transgender, queer and questioning communities in the UK. Now, I'm very fortunate to have a wonderful special guest with me. Welcome to OJC Poddy, Liz Ahern.
Thank you, Eva, and thank you, Rach, as well, for assisting us. I'm a long-time listener, first-time caller, so great to be here.
Fantastic. And Liz, who better than you to give us insights into your community? This does focus on patients, but I'm sure there are huge practitioner needs as well. So if you can, will we walk through this paper?
Yeah, absolutely. Yeah. As you've said, there's an article which is an opinion piece in the Lancet Oncology, but it really points to this, what I think is really an excellent position paper about improving care for sexual and gender minorities from the UK colleagues. And interestingly, Eva, it is virtually all about patients, but they give a 10-point plan or call to action of 10 steps. And the 10th one is to encourage diversity within the oncology workforce as well. So I think this is another one of those situations where representation matters, and that could be for a patient who's a member of a sexual and gender minority group, seeing out and proud members of the oncology workforce or the hospital workforce or clinic workforce who are well supported and happy in their environment. It can also mean improving the environment in other ways. So suggestions that often come up in literature around this is displaying visual markers of acceptance like the rainbow flag and the transgender flag and things like that. So yeah, it's, as you say, an excellent publication, generally focused on patients, but also encompassing, I guess, sexually and gender diverse oncology workforce members as well, which is fantastic.
Do we have any information, Liz, on the numbers of people in those groups in any oncology workforces around the globe?
I'm not an expert in that area and I don't actually know. I think it might be a situation like what we see with the patient statistics, where we don't know because we don't have the data recorded. And that's one of the major themes that recurs through the position paper and also through the Lancet Oncology opinion piece, which is that it's hard to study an issue if you're not collecting data around it. So I don't know the answer to that, but I think for those of us who are watching the literature, it's clear that it's a topic that it is receiving more attention, I think, over the past few years and this is the latest of those, I think, and one of the most substantial, given that it's a position paper from these professional groups. But we have seen other articles from time to time elsewhere, for example, from ASCO. And, I think putting it in perspective overall, it's a very timely focus. We know that the oncology community is looking at issues of equality and diversity. We all know at ASCO this year, the presidential theme was equality, every patient, every day, everywhere. And so I think thinking about these issues comes under that umbrella.
On first glance, you might think, why do we need to know these personal details? Whose business is it? But as you say, the position statement points out a number of things. Firstly, we can't really study issues well if we don't have the data. But also with relation to cancer patients, they really are an underserved minority. We know that they have poorer outcomes generally. Some patient groups, and the documents at pain to point out this is a very heterogeneous group like any minority group, but some have higher cancer risk factors, perhaps related to HPV infection or tobacco consumption. They also may have complex completing comorbidities. They highlight anxiety and depression and a negative interaction or engagement with healthcare services. And the big buzzword, of course, is intersectionality. And I'm going to ask my co-host, Craig Underhill, to jump on and tell us what intersectionality is.
Oh, that sounds like something to do with the border crossing in between New South Wales and Victoria or something, Eva.
Yeah, you've really got the border on your mind at the moment with all these COVID closures. Liz, would you like to explain intersectionality?
Yeah, I think that's a really critical point. So intersectionality, I'm not a sociologist, so I'll try my best to explain it, but I guess it's the recognition that multiple memberships of different marginalised groups can occur concurrently in people, and therefore we can't really focus on one thing without considering the whole range, I guess, of social factors. So, when it relates to this group, so LGBTQ people, some people describe that as like an alphabet soup. And I think, really it's an umbrella term that covers a lot of ground, and certainly not everybody in this group is the same. So I myself am a queer woman. I am a cisgender woman, and I'm a white person as well. So for those who aren't familiar with the terminology, cisgender means those of us who identify with the gender assigned at birth. And that's in contrast to other identities such as transgender or agender or non-binary people. And, I think it's really worthwhile thinking about the competing issues that would be focused, that would be faced, I guess, by people in those different groups. I think queer people, LGBTIQ plus people can be people of colour. They can be Indigenous. They can be brother boys and sister girls from the Indigenous community or queer people. They can be asylum seekers. They can be parents. They can live in poverty. So people who are in this community are at excess risk of living in poverty, and they can face a lot of different types of discrimination on the basis of gender identity and sexuality. And it's not a homogenous experience at all. But I think, considering it as a group and putting these issues on the table is a good start. And just circling back to what you said before, Eva, where the initial thought is, what business is it of ours? I think that gets to an issue which I think, in fairness, is not restricted to non-LGBTIQ people. I mean, I'm a queer person and I still struggle in consultations to know how best to ask some of these questions which feel a little bit awkward, when you first meet a patient. So asking things about sexual orientation and gender identity. And I think really we need to get into this, but I think there needs to be more patient-driven research into the best ways of doing that. If people want to leap in and they feel confident to do so, I think that's fantastic. But I think a lot of us do struggle a bit with the best way to put it and would really benefit from some more training and research in the area.
So, Liz, exactly that point was made in this article that quoted a survey of around 260 UK oncologists. And while people said they felt very comfortable treating LGBTQ plus patients, less than 10% really felt they had adequate knowledge of their specific needs. And about 70% wanted some specific training. And I can see a little project for us, Liz, doing this perhaps with MOGA or perhaps in partnership with ASCO and some of the other organisations, but in enhancing particularly training workforce, but also the older workforce who perhaps may more than even the younger workforce need some training. Just coming to some of the 10 comments, the first 3 were education and training. So integrating cancer care considerations for LGBTQ plus patients into training and assessment of the oncology workforce, co-designed education and training materials, and encouraging local training in cultural competency. The next 3 were data collection, and they suggest recording sexual orientation, gender identity, preferred name and pronouns as part of routine oncology consultations, and recording this information in registries, which we don't do at the moment, and with our primary and secondary care providers, and supporting audit and QI of the care of LGBTQ plus patients within oncology. The next 3 relate to research, encouraging participation in clinical trials, involvement in study conception and development, and also develop studies particularly pertinent to the specific healthcare needs of LGBTQ plus, and making sure study information material are inclusive of LGBTQ plus. And that got me thinking about our patient education. It is so much oriented towards a sort of a dominant white culture heterosexual couple. That must be pretty sort of a little offensive as a patient, what do you think?
I think, when I reflect on my experiences when I've been a patient at the GP or whatever, you just feel invisible, if this is, the term is called heteronormativity, which is the construct that everything's seen through the lens of everybody being straight. So that might be that, for example, they say, do you have a boyfriend or are you married? I know we've got gay marriage now, so that's maybe less of a heteronormative question, but, you just feel invisible. And I think starting off on that foot with a patient who may be a member of a sexuality or gender diverse community, it's just going to give them that hint that you're not really down with the lingo. You're probably not too savvy on these matters. And I think that it would make a lot of people less willing to open up. And overall, I think that they would feel that it was a slightly less safe space for them to be in, and a slightly less culturally competent space in terms of knowledge about LGBTIQ plus matters. So, I think sometimes it can be as simple as just making sure that there is some representation. It can be as simple as just making sure that we use language which is not making any assumptions about anybody. So, for example, saying, so do you have a partner, or tell me about your family? I sometimes say things like, tell me about your family. That could be your chosen family or your biological family. Chosen family is a buzzword in queer communities that sort of is used a lot to hint towards, I guess, the role that partners and friends play in our lives that can be more of a family-like situation. So, yeah, I think those sorts of things, although they seem small, are about representation, and that really matters. And it really is about the safety and the signals about cultural competency that you're giving out to those patients.
I think you're so right. And we have such unconscious bias, don't we? We see two women come into the consultation. We assume it's their sister or their friend. Then it can be a bit awkward when we make those assumptions. So I think we really need some training and just to be constantly reminded of this, because however difficult it is if you're healthy, it must be much worse if you're facing a cancer diagnosis.
Right. And, I think in this 10-point step as well that you were going through before, one of the points is engage in training in cultural competency and engage with humility with respect to feedback from LGBTQ plus patients. So, I think that is an awkward situation, and LGBTIQ practitioners are not immune as well from making those kind of assumptions from time to time, and it is embarrassing. But I think the best thing to do is to say, I'm sorry, I made an assumption there. If you're just sort of humble about it, take the feedback, say thank you for letting me know, and move on. I think people will find that quite an acceptable approach. But altogether, I think you're right, Eva. I think that it is a topic that is not easy, or it somehow feels difficult, I think, in the context of a medicalized interaction. And I think that we would really benefit from more training in it. And also, I think, from patient-led research into saying how members of the community would best like to be asked these things, whether that's written down at registration or face-to-face in the clinic, how we should word the questions. I think all that research needs to be done.
No, that's absolutely key. And Liz, just moving slightly away from this paper, but I'm sure everyone listening would be really interested to know, we think we're a very open society in Australia and modern, but is there a lot of bias and discrimination that, say, you've experienced or you feel members of your community have experienced within the oncology workforce or the hospital workforce?
I was thinking about this when I was in the hours leading up to this podcast today. I think I've not really heard of people experiencing a lot of direct discrimination. Having said that, my career has largely or almost completely been within large metropolitan hospitals in urban centres. The invisibility or assumptions of heteronormativity is something that I think everybody in my community would be hugely familiar with. And sometimes it can even seem comical that you've been mistaken for a straight single person, for example, can actually feel laughable to me. But we've all experienced that. The thing which stuck out in my recent background the most was that I was doing a PhD when that marriage survey or marriage referendum was going on. And I remember being in the lab one day and researchers from another lab were loudly discussing, the merits or disadvantages of gay marriage and, how they'd vote. And everybody's got a right to their opinion, but I felt a little bit humiliated that day. And I know that a lot of people in my community hold that experience. It's still quite fresh and raw for a lot of people. I do have lots of friends who are not medical doctors, but are transgender or gender diverse people, non-binary people. And I think that they face discrimination on a level which is constant and daily. This comes back to that issue of intersectionality. I've got friends who are Indigenous people who are queer. There's all different levels of discrimination that they face compared to me. So, it's still out there, unfortunately. I guess we can only hope that it's getting better for the younger generations. And I can say that now that I'm aged in my 40s. Next generation.
We could talk on and on about this. It's been a real privilege to have you come and discuss this seminal work, and I hope that this does spawn some interest amongst our listeners and perhaps really a movement to do some of that research and take those next steps.
So Liz, well done for coming on. Thanks. It was really just sitting back listening, a very honest and open discussion. So thank you so much. And I sort of had a bit of an epiphany. I thought, there's actually two things going on, isn't there? There's gender and then there's sexuality. I think a lot of people in the past have kind of just assumed that if someone was gender fluid, then they're probably gay, but it's a completely different issue, right? So when you were talking about intersectionality, that kind of realised that maybe we are a bit more evolved here. We do actually ask people about partners and don't assume. So we have lots of same gender couples come in, and I never assume that they're friends or brothers, and I do ask about partners, but I don't ask about chosen family.
That sounds like something for my nephews who are Jewish Aboriginals and they have a chosen family. So there's some intersectionality. I mean, people are incredibly diverse.
That's right, yeah.
And you just don't know it unless you ask. I guess unlike the colour of your skin, gender and sexuality is somewhat hidden, although people think they get clues from appearance or behaviour, I guess.
Yeah, that's right. But, that's quite right. I mean, you can have transgender people who are married to somebody with the opposite gender expression or with the same one. It's just, it's very, very much diversity. And as Eva has said, I think if you don't ask, you don't know.
Craig, you might be perfect at this, but this week I asked a man about his mother and it was his wife. So we always make assumptions when we're busy and we just have these assumptions.
That's possibly the worst mistake of all, Eve.
Yes, I had to backpedal very quickly and say I left my glasses in the room and blah, blah, blah. But yes, it was embarrassing. Part of a busy day, and you get young people married to older looking people and all sorts of things.
I'll tell you an anecdote. I had a transgender patient who went into male to female, if that's the correct thing to say, Liz, and she was chased out of Target because she went in to the ladies' change room and was trying on clothes, and they actually called the police.
This is part of that additional, daily discrimination that I think can be seen. And this is obviously one of those, without getting too political, it's one of those sort of culture war issues that happen and that has been going on in the United States for a few years about trans people in bathrooms. It's just a shame, really, because we're talking about people's lives.
And if they're affected by cancer, that would make it even worse, wouldn't it? If, they had need to use bathrooms, public bathrooms often, say they had a bowel resection or a stoma. What about issues with breast cancer and surgery for patients? There's all sorts of connotations that are stressful, and the intersectionality would make it even more difficult.
Yeah, so, having non-gendered bathrooms is a good start in that regard because just anybody can use it. I know sometimes people say, well, there's disabled bathrooms, but trans people are not disabled, but they just need access to a bathroom that's fits their gender identity.
Yeah. Look, we could talk on and on about this. It's been really great and a pleasure to cover this paper. I thought it was really key and fantastic that all of these issues are now coming front and centre. And to me, it's just as important as the latest data about a checkpoint inhibitor, because if we can't relate to our patients or appreciate them, doesn't matter what drugs we've got to offer.
Absolutely. Thanks for having me.
So, Craig, there will be issues such as transgender women who get prostate cancer.
I had a patient who's transgender who had prostate cancer and had really aggressive disease, I assume because she was on hormone replacement, that sort of drove the biology of the cancer, and she unfortunately was refractory to treatment, had a terribly painful death with bone metastases, was ostracised by the community because this was 20 years ago, ostracised by the community because she was transgender, lived in poverty. It was really quite sad and quite often very negative comments from staff.
Well, hopefully things have improved, but if anyone's listening and wants to share some stories, we'd love to hear from you. So thank you very much, Dr. Liz Ahern. It's been a great pleasure.
Thanks for having me. Thanks for covering this material.
Craig, it's time now for your main paper, all the way from St. Gallen. We wish we were there. What have you got for us?
I know, that was such a good meeting to go to, Eva. I remember staying actually over the border in southern Germany and getting a bus into St. Gallen, which is this quite tiny city in the top northeast corner of Switzerland, a university town where they have this meeting every year. It's a great meeting, kind of got absorbed into breast cancer for the week. But I went the day before, there was great snow. It was late in the season and I got a train up to ski resorts in the top of Austria. It was like a half an hour train ride and I was right at the top of the Alps and I had a selection of resorts. I went to 3 resorts that day. Went to the first one and went, this isn't so great. Asked a local which was their favourite resort and just got the bus down to the next one and it was all in the same ticket and stuff. I had a great day skiing. It's very memorable.
Thanks, Craig. Would you mind talking about the article?
So this is the 2021 St. Gallen International Consensus Guidelines for the Treatment of Early Breast Cancer, so just early, not advanced. So this is a key paper that comes out every 2 years. This year was an online meeting. There was a consensus panel that voted on various questions to come up with these guidelines. So people can obviously click on the link to get the detail, but I might just highlight a few things that took my eye when I had a read of this paper. I don't do so much, I'm not so much focused on breast cancer now, but I still look after some patients with breast cancer. And I think anyone really in the breast cancer field need to read this paper and be across it, especially all the trainees. So the focus was really customising recommendations for the treatment of early breast cancer with an increasing recognition that the care of the breast cancer patient depends on individualised clinical features, including the biological subset and genetic factors underlying the breast cancer risk, genomic signatures, the extent of response prior to surgery for those who had neoadjuvant treatment, and, of course, patient preferences. So that's sort of the flavour of the change from 2019. In the past, the panel favoured genetic counselling, germline testing for those patients with whose age of breast cancer onset or family history, presence of male breast cancers and tumour subtypes were more likely to identify a familial cause of breast cancer. So similarly, the panel didn't recommend universal testing for all in 2021, but a growing percentage of panellists favoured genetic testing for all breast cancer patients diagnosed at less than 65. That would be a change in practice if we were to adopt routinely doing it in everyone under 65. They did talk about there's various genes and the different penetrance of the genes, and that's BRCA1 and BRCA2, and PALB2, they have a stronger penetrance and so have a stronger predilection for clinical effect and the need to adjust treatment accordingly as compared to the other underlying genes that can be tested for. But it was really interesting following on from ASCO and our discussion about the Olympia study and the controversy about accepting progression-free survival as the right endpoint, but 93% of the panelists strongly endorsed adjuvant olaparib for women with stage 2 or 3 HER2-negative cancers, meeting the eligibility criteria of the Olympia study. So that's really interesting. They've embraced the results of that study, even though there's no overall survival data yet.
So, Craig, anything interesting or developments in pathology?
Yeah, so we've had the traditional ER, PR, HER2, and so now the trend is also to include maybe a threshold. Changing the thresholds for ER might be 10%, maybe more appropriate. There was division about the change in the guidelines to that. There was ongoing controversy about whether Ki-67 should be used as a surrogate for determining whether patients should receive chemotherapy or not. The consensus was that tumours less than Ki-67, less than 5%, shouldn't receive chemotherapy, while those over 30% definitely should receive chemotherapy. So that's, again, a little bit controversial. But in the absence of availability of genomic testing, Ki-67 appears to be a valid marker of tumour proliferation, because, of course, most health systems can't afford a 70 gene or a 21 gene recurrence score, but Ki-67 is pretty cheap. But in an ideal world, they did recommend they should be done. TILs, tumor-infiltrating lymphocytes, PD-1, PD-L1 expression is a prognostic marker in triple negative, but not yet ready to be part of the decision-making process for adjuvant. Loco-regional, there wasn't a huge amount new in that. There's discussion about some elderly patients not requiring lymph node biopsies, and basically 1 or 2 nodes you don't need to go on and do an axillary dissection. There's interest in hypofractionation. They basically thought the standard treatment should be 15 or 16 treatments. So that's a little bit different probably to the standard applied in Australia. But they thought that partial breast irradiation and ultra-short course 5-fraction approaches were not ready for prime time.
Oh, that's interesting. Now, what about neoadjuvant? We have seen our surgeons embrace this to the point where the oncologists are saying, no, not for this patient.
I think there's still quite a variation in care in Australia, but they basically said for stage 2 or 3, so node positive clinically, or the stage 3 of the more than 5 centimetres or supraclavicular nodes, HER2 positive or triple negative, that should be the standard care, including in the higher stage ER positive. So that was interesting. The preferred neoadjuvant treatments for HER2 is a combination of trastuzumab, pertuzumab, paired with taxane and either an anthracycline or platinum. Triple negative, dose dense anthracycline and taxane, which is unchanged. They did not recommend immune checkpoint inhibitors as part of the neoadjuvant for triple negative. And they were divided about the role of carboplatin added to the neoadjuvant anthracycline, taxane or alkylator in that group of triple negative patients. But basically then talked about post-neoadjuvant therapy. So people can look at the detail, but in the patients with residual disease following preoperative treatment, they give some guidelines as to which treatments to give in the adjuvant setting post-operatively. Still recommending in systemic therapy. Again, there's some good tables and advice in there categorised according to HER2 positivity or triple negative. And then in the ER setting for the stage 1 patients, they're now favouring 5 years of tamoxifen or AI, and only for the node positive looking at extended therapy for a duration of 5 years.
So that's a little bit of a change because there was a vogue for 10 years for everyone some time ago.
They're now stratifying. They were divided about the use of abimaclacib adjuvant therapy. We've seen in the Monarch E study.
Abemaciclib.
Yeah,
Come on.
thank you. In the Monarch E study, again, another controversial study with a 2-year follow-up showing an improvement in disease-free survival. And so some panelists were recommending that in high-risk patients with 4 or more nodes positive, but it was really, again, controversial. There's some good discussion about the use of genomically informed chemotherapy decision-making based on the TAILOR-X, RX-Ponder and MINDAX studies, and people can read about that. But they basically recommended that against the use of adjuvant chemotherapy in postmenopausal women with stage 1 or 2 up to 3 nodes positive that had low risk genomic signatures scores of less than 25 or low risk on the 70 gene. So they give some guidance about, the use of those technologies if they're available. And then people again can refer to the paper, but there is a section about oligometastatic breast cancer recommending that they be treated aggressively if there's after staging. And there's a section on survivorship for the first time, addressing some of the issues such as changes to the body, hair loss, chemotoxicities, estrogen deprivation, etc. So that's included in that consensus guidelines for the first time. So there's lots and lots of information.
How long's the document? Sounds huge.
I accidentally pressed print. It was about 100 pages.
Oh, wow. Okay.
With the references. So it really is, an important paper for those treating breast cancer or trainees to have a look at. The actual reading that is not 100 papers. That's with all the references and tables. It's well worth a read.
Thank you so much. I'm going to flick into a couple of quick bites. So my first one is a paper by Hibino in ESMO Open. And again, I know I bang on about this a bit. This was using the European Society of Medical Oncology magnitude of clinical benefit scale, but in this paper to score the clinical benefits of precision medicine in treating solid cancers. And basically 3 reviewers used both the ESMO scale and the ASCO value framework. And if you have forgotten what these are, please go back and listen to our poddies where we went through this in great detail. Basically, the bottom line is that precision oncology strategies are not as effective as we think they are. It's a little bit of a misnomer. Some of them are very good, but the magnitude of benefit scores varied between 0 and 4. So we've still got a long way to go.
So, Eva, what else have you got?
A very brief mention of this interesting paper called Randomized Controlled Trials versus Real-World Data in the COVID-19 Era, a False Narrative. It's a really good summary of the pros and cons of RCT versus various forms of real-world data, everything from huge databases like SEER to billing systems, which is where we get a lot of our information, big data from, and registries. So I did want to jump, though, to a little bit of data in one of the populations we keep returning to. This time it's older adult women with ovarian cancer. This was a study entitled Efficacy and Safety of First-Line Single-Agent Carboplatin versus carboplatin plus paclitaxel for vulnerable older adult women with ovarian cancer. It was a randomized clinical trial, and it actually had to be terminated earlier because of the inferior outcome of the single agent versus the doublet. So again, appropriate treatment of elderly patients, appropriate assessment. But now, Craig, I'm sure you're aware. I'll give you a little quiz. Do you want a quiz?
I'm really bad at your quizzes, Eva.
That's why I love to give them to you. Now, tell me some of the stuff in the literature that's...
You keep giving me a heads up about this.
I shouldn't I? No, look, it's interesting because there are all these papers coming out all the time about what it is that affects the efficacy of immunotherapy to do with the host. So we've had microbiome, antibiotics. We've even had cannabis use affecting response. Now we've got a paper in Gut looking at Helicobacter pylori. And this was a paper that went from mouse and cell lines into some retrospective databases, but basically show a negative impact of the presence of Helicobacter by serology. So much so that they suggest that using this might be a powerful tool, quote, to personalise cancer immunotherapy treatment. So stomach microbiota, obviously, with Helicobacter predicting IO outcome. Great. So, look, I do have one other short bite, and it sort of brings us a nice segue back to what we were talking about in the start of the podcast. Again, perceptions and bias. And this is a paper that's called Gender Bias in the Estimation of Others' Pain. And what they did was show facial clips of female and male patients who had chronic shoulder pain. The study group was asked to estimate the patient's pain intensity. And over 2 studies, guess what? Perceivers underestimated females' patients' pain compared with the male's pain. And they had prescribed more psychotherapy for females versus more pain medicine for males. So I'm sure this also applies to hand surgery. And so you all feel sorry for hands. But when I had my hand surgery, I didn't get any sympathy. So that just proves 100% what this paper's talking about, obviously.
Yes, but can I question, in view of the discussion earlier, was this people identified themselves as male and female, or they're cisgender, or?
Yes, that's a good question. They didn't give that level of detail. Life is getting very complicated. So, Craig, what are your quick bites?
Well, I've done a few interesting ones, Eva. I've got one hot off the press in the JCO. It's a randomised phase 2 trial evaluating 2 sequential treatments in first-line metastatic pancreatic study, the Pan-Optimox Prodigy 35 trial. So that was interesting. Patients randomised to get 6 months of FOLFIRINOX with advanced pancreas cancer versus 4 months of FOLFIRINOX followed by leucovorin 5-FU maintenance therapy, or a sequential treatment of alternating GEM, 5-FU, leucovorin, irinotecan. A was the winner of the 3 with a 6-month progression-free survival of 47% in arm A, 42.9 B, 34 in C, and overall survival 10 versus 11 versus 7 months. No deterioration in quality of life seen in a maintenance arm. So I thought I'd phone a key opinion leader in GI to comment about this paper. Hang on, I'm just going to get her on the phone.
Oh, hang on. Sorry, Craig. I've just got to take this call.
Eva, it's Craig.
You're on the podcast with me.
Yeah,
Why are you ringing me up?
Comment about this Optimox Prodigy trial. What did you think?
It's Prodige. I thought you're Mr. French. Mr. France. Look, I think there's probably quite a bit of selection bias in that. If you didn't think your patient was fit enough for FOLFIRINOX, you wouldn't put them in the study. You know, this is also another one where 9 versus 10 months, if you put it in terms of weeks, 7, there are no huge gains here.
No.
And we recently had the ASCO abstract in locally advanced pancreas comparing directly gemabraxane with FOLFIRINOX, showing no difference in the locally advanced setting, and it probably relates to other settings. Maintenance is a good question.
Yeah, so in your routine practice, you just give them a break after FOLFIRINOX. You're not going to go on to maintenance. What do you think about it in some people? It kind of makes sense because we do it in other GI cancers like colon, so...
We're not used to doing it in pancreas cancer, but we are seeing some better responses. And yes, I think it depends on the different toxicities. Obviously, oxaliplatin, you're going to be limited by neuropathy, depends on tolerability. So we're entering new paradigms.
Thanks, Eva. We're just going through the quick bite. So thanks so much for coming on the podcast. Back to the podcast.
Yeah, it's my podcast. So can you get off the phone and we'll go back to the podcast? Hilarious. Right, Craig, what else have you got?
A paper from, it turns out, look, it took my eye and then I realised after reading it, it's actually from some authors in Sydney, some investigators in Sydney. So it's Pei Si Kok is the first author, Chi Kun Lee is the senior author. So they looked at tumour response endpoints as surrogates for overall survival in immune checkpoint inhibitor trials, a systematic review and meta-analysis. So it's in a recent edition of JCO Precision Oncology. And they basically went through 58 randomised controlled trials, 20 non-randomised controlled trials, and looked at whether the 6-month durable response or the overall survival correlated with survival, and it didn't, but it was predictive of prognosis at 12 months overall survival. So a poor surrogate endpoint, but interesting that it could be used for screening activity of novel agents in early phase non-randomised trials because of this relationship between response rate and 6-month durable response was prognostic of survival. So anyway, interesting paper.
Shout out to Pacey. Hi, Pacey. She used to be my registrar. And
wow. I didn't know that.
Always we have to go back and check endpoints with our international expert, Bish. If you missed our special OJC endpoints and highlights from ASCO with our very good friend Bish, don't forget to check it out. Now, Craig, any more?
Last quick bite. Clinical outcomes of molecular tumour boards, a systematic review. So we're getting invited now to patients who have molecular testing to then present them at tumour boards, but does it do any good for the patient? So this was a systematic review looking at 14 studies, 3,300 patients, looking at whether there was a benefit to the patient if they received molecular tumour board recommended therapy. And in fact, the data was limited because of a lack of prospective randomised controlled trials, but the molecular tumour boards did appear to improve clinical outcomes for patients with cancer. So just again, sometimes you sort of wonder why we go to all this effort. Does it actually make a difference? And this paper suggests that it does.
Did they have any comment about whether this was done in real time? Because that's my issue. Wait for the next tumour board in a month.
No, I don't think that was that detail in there either.
So my point is that they'll need to be on the schedule every week, and that's another MDT, isn't it?
That's right. So how often do you have them at Monash? Is it a week? You do it ad hoc, don't you?
We're not funded to attend molecular tumour boards. We have no time. We have lots and lots of patients. We have really no funded testing apart from the routine testing that people are very familiar with. We've had some projects, but it is a really fraught issue. In fact, we were about to start a real-time tumour board, and, one of the problems is the availability of the molecular pathologist. They're a rare breed as well, so it's a big workforce issue. Who's going to coordinate it? Who's going to get the samples to come in? Which patients do we choose? All those issues. What about you? Do you have one?
No, of course not. We don't. We're just small breed either, but we don't. We log into either your own or the Peter Mac one as we have a patient. So, in fact, Peter Mac has a good system. They will notify you that your patient's being presented. It's on a Friday afternoon, and you can present the clinical details, and they go through the NGS. So I think, it's one thing to order the NGS, but having those experts to then give some recommendations with whether those, mutations are of relevance or not, I think is pretty important. And possibly more importantly, going forward, for those rare mutations, we do need to have a better system in place for things like teletrials to make the treatments accessible to as many people as possible.
Yeah, even the knowledge, for example, if a patient's discussed at Peter Mac, whether there's a trial somewhere else for that. But yes, I think it does highlight the point that we all need the resources of Peter Mac, that Peter Mac has, to be able to do this properly.
Well, I think maybe, that lends itself to having a statewide tumour board. So maybe it doesn't need to be institutional based. It's something that probably needs to be accessible to everybody, because with pandemics proved you can do it by Zoom, right?
Yes, equity across services. I'm all for that, Craig. So look, just a shout out for our upcoming special OJC podcast. Craig, I'm really excited about this one. Do you know what it is?
No.
It's going to be the paper that most changed my practice. And we're going to ask our audience to volunteer, present a paper, and we're also going to try and get some of our superstar international colleagues to appear. So if you want to come and present the paper that changed your practice, please contact us at the OJC podcast. But other than that,
great topic.
It's once again, hope you get better hands. Otherwise, he might, if he loses his hands, he'll just be called Han. Bad joke. Over and out. See you, Craig. See you, Ray. Bye.
Bye. Get well soon, Hans.
You've been listening to the Oncology Podcast. If you enjoyed today's edition and would like to subscribe, head over to our website, oncologynews.com.au, and sign up to our newsletter. Thanks for listening.